Welcome, everyone, to our panel, Clinically Vetted AI in Action. I am delighted to be here with two amazing perspectives, Lee's perspective from the healthcare system and Ross's perspective from industry. And you have to speak on behalf of the entirety of industry. I'm just kidding. But let's get started because we only have 15 minutes. And I'm going to have each of them introduce themselves while they're answering the next question. But let's start, Lee, with you, if you don't mind. What is a validation lab or an assessment lab? What's an AI assessment lab, and what's the value to healthcare systems potentially?
So I'm Lee Schwamm, and there we go. I'm Lee Schwamm. I'm a stroke neurologist by my clinical training. I'm the Chief Digital Health Officer at Yale and Yale New Haven Health System. So in this role, I'm a purchaser of AI software. And I think I made some comments in a session here previously this morning, but I think when you are trying to decide whether or not you're going to purchase an AI algorithm, you really want to know three things. First of all, you want to see the car sticker. You want to know, what did the vendor do to validate this? How did they build it? What was the representative population? Does it look like my population? And do I think that the math is credible? And ideally, I get that in the form of something like a model card, which Chai has been promoting, but a standardized way so I can compare one product to the next. But the next and most important question is, how do I know if it's any good? Do I really trust the vendor and only the vendor to tell me that it's good? Because every vendor in this hall will try to convince me that their product is the best product. So where is the Consumer Reports equivalent of product evaluation? And I think that's where assessment labs come in. I like the term assessment rather than validation lab, because many times we also don't even have a gold standard for what we would validate against. So I'm very fortunate. I sit at a university health system that has AI developers like Stanford. We have a very robust validation and assessment mechanism internally, but it still is a problem for me, and it's a huge problem for health systems that don't have that level of infrastructure, because I have hundreds of algorithms that are coming at us now, and I don't have the bandwidth to validate every single one of them either. So ideally, there would be a third-party independent mechanism that I could, from a source I could trust, that could create either a representative sample of the United States, or even better, take their sample and configure it so it looks just like my health system and run the algorithm. Now, I think that is very reassuring if it's a fairly straightforward algorithm, like a predictive algorithm that doesn't depend on my workflow. If it's workflow dependent, then that validation assessment may only get you so far, but it's still way better than the alternative of just flying blind and saying, well, I trust that it's going to work.
And here we're talking about traditional AI tools, right?
Yeah.
Yeah.
Okay. And we have a real double standard here when it comes to thinking about assessments and validations, because we have all, as clinicians, been working with low-level predictive algorithms forever, right? They're logistic regressions. We have point scores. I would challenge anyone in the entire conference to tell me that they did a 5-year validation of the CHADS-VASC score on their patients with atrial fibrillation to see who actually ended up having a stroke and who didn't. We accept these tools, and we accept that they're fairly static. We know that the new algorithms are very dynamic.
Yes.
And so the assessment doesn't just stop at implementation. Ideally, it continues through post-deployment, and I think that's a second business model iteration for these assessment labs is, let me validate it, assess it for you before you buy it, and then let me partner with you to validate it in your population going forward at pre-specified intervals.
Got it. So there are important jobs to be done before the purchase decision or pre-deployment, and then after deployment, and thinking about monitoring and evaluation of, are you actually creating the value you expected to create? Okay, wonderful. And then Ross, I want to go to you next. So, and I should have mentioned this earlier, but I'm Sneha Jain, I'm from Stanford, so also the health system perspective. I spend half my time seeing patients and the other half thinking about AI tool evaluation and deployment at Stanford Hospital.
And then the other half writing papers.
And the other half writing papers, exactly. And Ross, you're actually in industry, building these tools, trying to get them deployed. So what's keeping you up at night when you go from a tool that you've developed and worked on and really perfected as much as possible, to going down the line to actually getting it implemented and impacting patients?
Yeah, it's a great question. So I'm founder of Ultromics. We make AI diagnostic tools for HFpEF and amyloidosis, specifically on echocardiography. And I think crossing the chasm between FDA clearance and getting broad clinical implementation is one of the most difficult journeys a startup or a developer has to take. And when we think about clinical implementation, we think about kind of 5 phases. The first phase starts from actually pre-FDA. How do I design my algorithm to start with? Because if you design it incorrectly, it's going to make the clinical implementation so much harder. And we work through a simple framework, which we call the AI diagnostic triangle, where you start with a disease that goes underdiagnosed. Point number 1. Point number 2, that undiagnosis or misdiagnosis leads to a big problem, like heart failure hospitalizations. And point number 3, there has to be a therapy or an intervention that helps reduce that problem.
So it's got to be actionable, some action you can take.
It's got to have actionable, and that really helps with the clinical implementation. If you turn up with an algorithm that doesn't have those things, it makes the implementation so much harder. The next point is obviously FDA clearance, and people have this misconception that once you FDA clear something, you're ready to sell. You're there. And sure, it allows you to market your device, but actually completing that sale, completing the commercialization, you've got many more steps to go before you can achieve that hurdle.
Can you spend some time on that? Because I think that's something that people don't understand, like you mentioned. And 95% of AI tools are 510K cleared, right?
Correct.
What does that mean?
Well, so I think a lot of startups can get to the FDA clearance, and what they will tell their investors is, once we're FDA cleared, here's our commercial ramp up, right? And they'll put these projections up. And so they get funded to FDA clearance, but don't realize that they've got 1, 2, maybe 3 more years before they set it up. So steps 3 to 5 of the commercial implementation phase are the hardest. Step 3 is workflow, both IT and clinical, both equally important. So from an IT workflow, you've got to decide whether you're going to partner with someone or go yourself, and that's a big decision as a startup as to whether you go. If you go yourself, you then have to put all the various IT approvals, certifications in place, which is a big, big process. And then it's the clinical workflow. How do you actually implement it? Who do you run your AI algorithm on? Which patients? How do you set that up for the clinician so it's seamless? I think amyloidosis is a great example of that. You can't run an amyloid algorithm on every single patient that comes through an echo. That would be inappropriate. And more than that, the prevalence of amyloidosis in the general echo population is probably 1% maybe. So your positive predictive value has got to be extraordinarily high for that to make sense. So you have to set up the workflow where you can enrich the population first. And we do that by actually running HFpEF first, and any HFpEF positive then feeds through to a cardiac amyloidosis patient. And you go from a prevalence of about 1% to a prevalence of 5 to 10%, making that running of amyloidosis lead to less false positives without missing too much amyloidosis. So you've got to really think about how you implement this clinically. So that's step number 3. Step number 4.
Can I just interject for 1 second? Just simple math. A disease with 5% prevalence and a screening test with 99% sensitivity and specificity will give you a maximum positive predictive value less than 50%, usually closer to 25%. And none of our tests have those characteristics. So prevalence is an extraordinarily important part of this, which you don't control. It's the population prevalence is what it is. So enriching the population before the algorithm turns out to be an incredibly important step.
And layering it. Sorry to interrupt you further, but I think that you're bringing up such important points that I hope the audience takes away from this, because in so many of the AI posters and moderated sessions we have, there's a focus on AUROC and on all these statistics. There is less focus on positive predictive value based on prevalence, and there's even less focus on clinical workflows and the bottlenecks that occur and the capacity constraints that occur that will matter when you actually think about whether your AI augmented whatever, workflow, clinic, anything, creates value. And so part of what I'm hearing from you is you have to enrich your population before, maybe you have to have multiple layers of tools or evaluation frameworks to bump up your specificity to increase the true positives, decrease the false positives that flow through your clinic.
Exactly. And then you've got the final two steps. Step 4 is post-market validation. How does your algorithm perform in real-world, messy data? That's something you can't necessarily prepare for by going through the FDA. You have to put it out there in the wild, and you have to see how it performs in that data. And how does it perform against, maybe there's a new ultrasound cart, or the PACS compresses images in a way that your algorithm's never seen before. These are all the things that you would only learn post-FDA once you've actually got clearance to make your algorithms robust to it. And then finally, it's the health economics piece. You've got to make sure that you provide systemic value through your health economics. That's both to the provider and to the payer, and that eventually leads to reimbursement. So only once you've achieved those 5 kind of clinical implementation steps can you really scale an AI algorithm commercially. So it's not just getting FDA clearance. And this is where I think the AHA assessment lab can really, really help. They help you cross that chasm much more with less friction. So one of the great things that the assessment lab has done is they've collated the system-wide data from 3 or 4 different health systems, hundreds of thousands of patients, and you can run these mass validation trials, something that would have cost a startup lots of money historically and taken many, many years. You can do now in months or even weeks via the AHA assessment lab. So I think it's a really important initiative to help startups cross that chasm from FDA clearance through to clinical implementation.
Yeah, I just want to make another observation about what I would call a cognitive framing bias. Most clinicians, when they hear that something is FDA approved, most of their interaction with that is around drugs. And for FDA approval of drugs and biologics, you have to show clinical efficacy. So the bar is really high, and it's like a stamp of approval. If it's FDA approved for that indication, it's probably useful in a lot of other things, but it's certainly useful in that. For devices, FDA regulation, particularly on 510K, which means there's a predicate device that already proved something, and you're just saying, I look like that thing, so I should have the same results. That's that's really more like a corkscrew, right? This corkscrew will pull the cork out of the bottle. It won't tell you if it comes out in one piece. It won't tell you if the wine tastes good. It just says it'll do the job and it won't break in the process. If it doesn't work well in the hands of the operator, after 2 or 3 tries, they just throw it away and go to the next one. So since we regulate software as a medical device, like a device, FDA approval, if you can't get FDA approval for your device, that's a problem. But I agree completely. That doesn't unlock any more doors from my perspective. And the sad reality is that for most AI algorithms, the predicate device is a non-AI algorithm. So I don't really buy even the predicate nature of that.
Wow, okay. Somehow we're already at 14 minutes. So what I would love to hear from each of you is what you hope the audience takes away from this, part 1, and we have 2 minutes. Okay, good. So part 1, what you hope the audience takes away from this conversation, and 2, what do you think the role of the AHA is? Validation lab, but also more generally. And I keep saying validation lab, assessment lab. That is the right terminology.
I really like what Ross said. Organizations like the AHA, if they can, through their trusted, honest broker relationship, gather extremely large data sets that ideally might even include some connected association to workflows as to how those data, when sequentially in the course of an admission or an episode they are collected, it enhances the likely generalizability of AI algorithms, where the risk of overfitting and being overly trained on one institution's data are a big risk to the ability to generalize that and market it successfully across multiple organizations. So I think what I would wish for is some federated learning model where we can aggregate enormous amounts of data maybe even on a per algorithm use, where health systems get a little fee, like a toll booth, every time their data is accessed for training or assessment. But the reach and the breadth of that data is incredibly rich. That would be a great benefit to everybody.
Ross.
Yeah, I think many startups aren't successful in crossing the chasm from FDA clearance to a commercially scaled product in health systems. And I think the AHA Assessment Lab will help enable that. Look, let's face it, every clinician you speak to when you're trying to sell them a product will want to see the algorithm work on their data. They won't trust your other data. But the AHA Assessment Lab data sets is so vast, it will hopefully really help with that question and enable startups to cross that chasm.
Wonderful. Thank you for this really great discussion. We are now at time, but I want to invite you all to continue the conversation on the other side of this wall. There is a booth for the AI Assessment Lab, and we would love to discuss that with you there. Thank you.
Thank you.
Thank you.